Burned out rheumatism typically refers to a stage in certain chronic inflammatory rheumatic conditions where active inflammation decreases, but joint damage, deformities, or functional impairments persist. This
الله
term is
أكبر.
often used informally and may apply to diseases like rheumatoid arthritis, RA, where aggressive inflammation in earlier stages may leave behind residual joint damage even after disease activity subsides or is well controlled. Key features. 1. Inactive inflammation. Laboratory markers like ESR and CRP may return to normal, and symptoms like joint swelling and pain improve. 2. Structural damage. Joint deformities or ankylosis can occur, limiting movement and causing functional disability. 3. Pain and stiffness. Chronic pain may persist due to mechanical or degenerative changes rather than active inflammation. 4. Fibrosis. Soft tissues around joints may harden or scar, contributing to stiffness and reduced mobility. Causes. Long-standing inflammation before effective treatment, late diagnosis or delayed treatment, inadequate control of disease activity in earlier stages, secondary osteoarthritis due to joint damage. Management. Physical therapy to improve joint mobility and reduce stiffness. Assistive devices to aid in daily activities if deformities are severe. Surgical interventions, joint replacement or corrective surgeries for severe cases. Pain management, nonsteroidal anti-inflammatory drugs, NSAIDs, analgesics, or corticosteroid injections for chronic pain. Preventive care, early and aggressive treatment of rheumatic diseases to prevent progression to this stage. Would you like further details on managing a specific case or condition? The role of disease-modifying anti-rheumatic drugs, DMARDs, in burned-out rheumatism depends on whether there is any residual inflammatory activity. Here's a breakdown. When DMARDs may be useful. 1. Residual low-grade inflammation. Even if overt inflammation appears to have subsided, subtle ongoing inflammation, detected via imaging like MRI or ultrasound, may justify continued DMARD use to prevent further joint damage. 2. Autoantibody positivity. In diseases like rheumatoid arthritis, RA, persistent seropositivity, e.g. high levels of rheumatoid factor RF or anti-CCP antibodies, can indicate a risk of flare-ups, warranting maintenance therapy with DMARDs. 3. Prevention of secondary damage. In some cases, DMARDs, e.g. methotrexate hydroxychloroquine, may help minimize secondary complications like synovitis in adjacent joints. When DMARDs are unnecessary. 1. No active inflammation. If inflammatory markers, ESR, CRP, are normal and imaging shows no active synovitis, DMARDs might not be required. 2. End-stage joint disease. When joint damage is purely mechanical or degenerative, DMARDs are unlikely to provide benefits. Instead, focus shifts to pain management and physical therapy. 3. Adverse effects of DMARDs. In elderly or frail patients with burned-out disease, the risks of DMARD therapy might outweigh the benefits. Alternative focus for treatment, biologic DMARDs. Rarely considered unless there are systemic features or evidence of low-grade persistent inflammation. Symptomatic management, NSAIDs, physical rehabilitation, or joint injections. Surgical interventions, joint replacement or arthrodesis for severe damage. Would you like to discuss specific scenarios or DMARD options? DMARDs can play a crucial role in managing extra-articular manifestations of burned-out rheumatism, particularly in systemic autoimmune diseases like rheumatoid arthritis, RA, psoriatic arthritis, PSA, or systemic lupus erythematosus, SLE. These manifestations are often driven by ongoing systemic inflammation, even when joint disease appears burned out. Here's a detailed overview. When DMARDs are indicated. 1. Persistent systemic inflammation. Conditions like interstitial lung disease, ILD vasculitis, or pericarditis may still progress even if joint inflammation has subsided. DMARDs, methotrexate, azathioprine, mycophenolate mofetil help suppress systemic immune activity. 2. Organ involvement. Pulmonary involvement. Methotrexate is avoided due to potential lung toxicity, but mycophenolate mofetil or biologics like rituximab may be beneficial for RA-associated ILD. Cardiovascular manifestations. Hydroxychloroquine, HCQ, is particularly effective in reducing cardiovascular risks in SLE and RA. 3. Vasculitis. Extra-articular vasculitis in RA may respond well to methotrexate, leflunomide, or cyclophosphamide in severe cases. 4. Eye involvement. Uveitis or scleritis requires systemic treatment with DMARDs like methotrexate or biologics, e.g. adalimumab, to prevent vision loss. 5. Skin and mucosal involvement. DMARDs like methotrexate or apremilast may help manage severe psoriasis or mucosal ulcers in INFSA. When biologic DMARDs may be required. Biologic DMARDs are often preferred for severe extraarticular manifestations. 1. Rituximab, effective for RA-related vasculitis, ILD, and refractory systemic features. 2. TNF inhibitors, useful for scleritis, uveitis, or severe extraarticular inflammation in PSA or ankylosing spondylitis. 3. IL-6 inhibitors, e.g. tocilizumab, can help with systemic inflammation and may stabilize ILD. When DMARDs are not indicated. Burned out mechanical damage only. When systemic inflammation is absent and extraarticular involvement is not active, symptomatic management, e.g. NSAIDs or local therapies, is sufficient. Advanced organ damage. Irreversible fibrosis or damage, e.g. pulmonary fibrosis, may require supportive care rather than DMARDs.